Hello, welcome back to my YouTube channel. In this video, I am going to talk about how to approach to a patient with carotid artery stenosis. In your day-to-day clinical practice, many patients will come to you with the carotid artery Doppler report and ask you what to do next. My report is showing 60% stenosis, my report is showing 70% stenosis or 90% stenosis. What should I do next? This is a very difficult situation, a very confusing topic, very difficult to explain to the patients what to do next. So this article on European Society for Vascular Surgery 2023 clinical practice guidelines, this article talks in detail about how to approach to such kind of patients. It's a very extensive article. What I have taken is one flow chart which is going to clear most of our confusion. Here what they have done is they have divided the patients into asymptomatic and symptomatic patients. You can see here asymptomatic, okay, asymptomatic and symptomatic patients. Okay, so they have divided into two categories. In asymptomatic, if you see, patient can come with four kinds of reports. Okay, let us see here. These are the four kinds of reports they can come with. One, they can come and say you that my carotid artery stenosis is less than 60%. That means very minimal occlusion is there. In that case, what do you do? Because they don't have any symptom, they have less than 60% minimal stenosis, you just tell them to undergo BMT. What is BMT? Best medical therapy. And this is considered as class 1A recommendation. What is class 1 and level A recommendation? That I will tell you later. Next, they can have total occlusion of the carotid artery and yet they remain asymptomatic. How is it possible? Because the occlusion is very slow, there would be a lot of collateral formation and that would lead to recirculation to the affected areas and the patient remains asymptomatic. So in that case also you don't do anything, you just tell them to undergo best medical therapy. Third group of reports are near occlusion with a distal vessel collapse. What is the meaning of that? The occlusion is so severe, that is more than 99%, that the flow to the distal part of the vessel is very minimal, leading to collapse of the distal part. In this scenario also, if you do any intervention, it is not going to benefit. In fact, you may harm the patient, because whenever you intervene either with a carotid artery stenting or endarterectomy, which are the two options available, that may result in distal embolization of the plaque material, leading to a new stroke. So you are doing this to prevent the stroke, but you may end up causing stroke. So in these three category of patients, stenosis less than 60% or 100% occlusion, or near occlusion, that is more than 99% occlusion with a distal vessel collapse. In all these three category of patients, you just tell them to undergo best medical therapy. This is a very class 1 level A evidence. There should not be any doubt in this. Problem arises if they have stenosis between 60 to 99%. Here we have to look into three parameters: whether their life expectancy is more than 5 years, or whether they have a favorable anatomy, whether they have more than or equal to one feature suggesting higher risk of stroke on best medical therapy. What are those risk factors? It is given separately. You can go through the table later. So if any of these things are there, that means life expectancy is more than 5 years, there is a good favorable anatomy, and there is more than one risk factor for stroke even on best medical therapy, then you suggest them to undergo either carotid endarterectomy. CA means carotid endarterectomy with best medical therapy, or CAS means carotid artery stenting with best medical therapy. Among the two, there is favoritism towards carotid endarterectomy. Many people recommend that as a level, class 2A level B evidence, whereas carotid artery stenting is less superior compared to endarterectomy, and it comes under class 2B and level B evidence. Suppose if they have any of these, like if the life expectancy is very short, there is no favorable anatomy, and there is no further additional risk factors for stroke, then you can just suggest them to undergo best medical therapy. So when an asymptomatic patient comes to you, only scenario in which you are going to advise them to undergo intervention is when their stenosis is between 60 to 99% and they have very good life expectancy by at least 5 years, good favorable anatomy, and they have higher risk of stroke even on best medical therapy. In these two categories, in these three conditions, you suggest intervention for carotid artery stenosis. Among the two, either you can go for endarterectomy or stenting. Endarterectomy is better than stenting, and these two come under class 2 level class 2 recommendation and level B level of evidence. So when it comes to symptomatic approach to symptomatic patients, here also you can have 4 kind of reporting, or in fact 5 kinds of reporting can be there. One, if they have carotid artery stenosis of less than 50%, you see here less than 50%, it means very narrow, very minimal occlusion is there. In that case, logically speaking, what do you suggest? You just tell them to go for medical therapy. Or if there is total occlusion also, same thing. Total occlusion is there, patient is symptomatic, you are not going to achieve anything by opening up the vessel because already patient has developed infarction or whatever distal manifestation. Don't do anything. Near occlusion with a distal vessel collapse, same thing. But in these three group of patients, if they have recurrent symptoms even on best medical therapy, then you have to tell them to undergo endarterectomy or stenting. Understood? No? So generally, if you use the common sense, stenting, stenosis less than 50%, total occlusion of the carotid artery or near total occlusion with the distal vessel collapse, don't do anything, just advise them to undergo medical therapy. But if they have recurrent symptoms on BMT, then you go for stenting or endarterectomy. If they have more than 70% occlusion, you see here we will come to this category, 70% and less than 99% occlusion, then there is a very clear indication for carotid endarterectomy. It comes under class 1 and level A evidence. Stenting comes under class 2A. So 70 to 99%, you have no doubt, you just straight away subject them for carotid endarterectomy or stenting. Now here between 50 to 70%, the separate categories added here. Here also you can go for endarterectomy or stenting, but the recommendation is class 2A and class 2B respectively. So to summarize, both in asymptomatic and symptomatic patients, you remember one thing: if the stenosis is very minimal, that is less than 60% for asymptomatic, less than 50% for symptomatic, don't do anything, go for medical therapy. If there is total occlusion in either symptomatic or asymptomatic, whatever it is, total occlusion is there, don't do anything. If there is near total occlusion also with the distal vessel collapse, that time also you don't do anything. Okay, so only thing is in symptomatic patient, if they have recurrent symptoms, recurrent TIA, then you subject them for procedure. Now, in both the categories, a special group of patients are when they have stenosis in a moderate amount, like 60 to 99%. In that case, you go for procedure. In asymptomatic, you screen for these things like life expectancy, favorable anatomy, and other risk factors, and based on that, you take a call. Whereas in case of symptomatic, means they have come with the TIA or some symptoms suggestive of numbness or minor stroke or TIA, then intervention is suggested definitely when there is a stenosis between 70 to 99%. Between 50 to 70% also we can subject them for procedure, but that comes under class 2A or class 2B evidence or recommendation. I hope this is very clear. You should not have any confusion. So for you to understand class 1, you take any guidelines, any recommendation, there is class 1, class 2, class 3 recommendation. Class 1 means the evidence and there is general agreement that the treatment or procedure is very beneficial and useful and effective and it is recommended. Class 2, conflicting evidence are there, but if you consider benefit versus risk, benefit is more. So class 2A, there is significant benefit compared to risk. Class 2B, there is less benefit, I mean very minimal benefit over risk. So it may be considered. Class 3, definitely there is no doubt that it is not going to be useful and it is not recommended. Level of evidence is based on European Society of Cardiology. Uh, what it says is that there are three levels of evidence: level A, level B, level C. Level A is data derived from multiple randomized clinical trials or meta-analysis. Level B, data derived from single randomized control trial or large non-randomized studies. Level C is consensus of opinion of experts and small studies or retrospective studies. So we go for always level A evidence, to some extent level B also, but not level C. When it comes to recommendation, we go for class 1 and class 2 only, and class 3 definitely not recommended. Okay, so this is the gist of approach to patient with carotid artery stenosis. When they come with the report, don't be very hesitant, don't be confused. Use this, keep this flowchart with you and practice 2-3 times or practice multiple times, then definitely you will get a grip of the topic, and then you can easily guide the patient and make them benefit from the treatment options available. Thank you.